Thank you. And now I would like to welcome Ritu Yadav. She is the incoming cardiology fellow at SUNY Upstate. She's currently PGY3 at the Valley Verde Medical Center. So please go ahead.
Good afternoon, everyone. Today, I'm presenting Glucagon-Like peptide 1 receptor agonist in Transthyretin amyloidosis, a real-world analysis of cardiovascular outcomes. I have nothing to disclose. ATTR amyloidosis is a progressive infiltrative cardiomyopathy, which leads to myocardial amyloid deposition, and that can manifest as diastolic dysfunction, heart failure with preserved ejection fraction most commonly, and also increased risk of cardiovascular events. We do have some disease-modifying therapies, as we discussed this morning, but these patients with ATTR cardiomyopathy, they continue to experience substantial morbidity and mortality. Diabetes mellitus is one of the most common conditions to coexist with amyloidosis, and this can further worsen the cardiovascular outcome through the metabolic and inflammatory pathways. GLP-1 receptor agonists in recent trials, such as Summit trial and STEP-HFpEF trial, have showed significant cardiovascular benefits in patients with diabetes and heart failure by reduction in major adverse cardiovascular events and as well as heart failure related outcomes. But the patients with infiltrative cardiomyopathy, they have been underrepresented in these trials, and their safety and effectiveness of GLP-1 receptor agonist in this particular population remains poorly defined. We need real-world data to figure out their safety profile as well as their benefit profile. So objective of our study was to identify GLP-1 receptor agonist role in this high-risk population using the real-world data. We used retrospective cohort. We did a retrospective cohort study using Trinetics Global Collaboration Network. We identified the patients aged greater than 18 years old who had diabetes mellitus as well as were diagnosed with ATTR amyloidosis from 2005 to 2024. These patients were then divided into two groups, GLP-1 receptor agonist exposed group and the group that was not given any GLP-1 receptor agonist. To cover for any confounding factors, we did 1:1 propensity score matching for the demographics, their baseline comorbidities, lab values, as well as concomitant medication. The primary outcome in our study was all-cause mortality, and secondary outcomes were heart failure exacerbation events, major adverse cardiovascular events, and ventricular tachycardia and VFib, so arrhythmic events. These outcomes were assessed at 1 year following the GLP-1 receptor agonist initiation. So in our study is one of the large retrospective studies. We identified about 2,837 patients with ATTR amyloidosis, and then we looked up the GLP-1 receptor agonist effect on their cardiovascular outcomes. But after the propensity score matching, the total 574 well-matched patients were included, and each group, GLP-1 exposed and GLP-1 non-exposed group, had 287 patients. So one of the primary outcome, which was all-cause mortality, we found that the patients who were exposed to GLP-1 receptor agonist had significantly lower risk of all-cause mortality, relative risk factor 0.24. And a similar trend was observed in secondary outcomes as well. There was a significant reduction in the risk of major adverse cause event and heart failure exacerbations. Although the risk of VT and VFib was comparable at 1 year follow-up in both the groups. If you look at this propensity MASH analysis, these are the demographic factors and comorbidities. Both the groups are pretty well matched. They have the similar comorbidities and demographic, and again for medication, because if you look at the GDMT drugs, they're pretty well matched in both the groups. And these are the outcomes as evident by this chart. All-cause mortality significantly decreased in GLP-1 exposed, so was the heart failure and major adverse event, whereas the VT and VFib remain comparable in both groups. This is the Kaplan-Meier group. If you look at it, there's a separation after about 50 to 100 days of initiation of GLP-1 from the date of from the starting days of GLP-1 initiation. So we finally concluded that in our real-world study, GLP-1 receptor agonists are associated with significantly lower all-cause mortality, heart failure, exacerbation events, and major adverse cardiovascular event without any significant changes in arrhythmic events. Now, looking at it, why do we think that that happened? So as majority of the larger clinical trials have shown, the GLP-1 have shown consistent cardiovascular and renal protection in patients with diabetes and obesities, which provide a strong rationale for GLP-1 in ATTR amyloidosis, because most of these patients do have these underlying conditions. We don't have any direct studies on the mechanism of GLP-1 receptor agonists in ATTR amyloidosis, but in the recent studies done in animal models, GLP-1 receptor stimulation was associated with reduced amyloid beta toxicity and accumulation, which may suggest a potential amyloid modifying effect. So that could be a potential area that we need to explore and figure out if GLP-1 initiation could be associated with reduced toxicity of amyloid protein. While we have clear possible rationale for the heart failure exacerbation reduction and all-cause mortality reduction, the arrhythmic events remain neutral at 1 year. One of the possible explanation for that could be that these VT and VFib originate from arrhythmogenic substrate, which whereas most of the action of GLP-1 receptor agonists is to improve the metabolic and inflammatory process in the body. So possibly it does not have as much effect on the conductory disorders as the basic metabolic and cardiovascular health. But there are some key safety concerns with the initiation of GLP-1 receptor agonist in this particular population. Most of the patients with ATTR cardiomyopathy tend to be older and frail. So starting these GLP-1 receptor agonists is associated with volume depletion and dehydration. It can lead to sarcopenia and lean muscle loss, as well as rapid weight loss can lead to gallstone formation and cholecystitis. And in the rare cases, events of pancreatitis and visual issues have been reported. So for the future direction, we propose that there are a prospective study that are needed to conduct to confirm this observed survival and cardiovascular benefit that GLP-1 receptors have shown in ATTR amyloidosis population. We also need to do further basic science studies and mechanistic study to evaluate whether GLP-1 signaling influence myocardial inflammation and amyloid biology. As well as we need to figure out, we need to do for future trials to figure out the impact of treatment timing, duration, and how to combine this therapy with pre-existing ATTR-specific therapies, as well as finding out detailed arrhythmia phenotyping to address persistent arrhythmic risk. Thank you so much for your time and attention. I'm happy to take any questions. Thank you.
Thank you, Ritu. And I'm going to pass on to Dr. Underwood.
Sure. Are there any questions from the audience? Well, thank you. Thank you. Oh, I'm sorry. Oh, great. Fantastic.
Side effects, and then the amyloidosis population also has a lot of GI issues, and you touched on the volume depletion, dehydration. Was that tied to them having, really, really bad diarrhea, worse than you would expect for a regular patient when they started GLP-1s? Like, would you be really, really closely watching them for GI issues when you start them on GLP-1s?
Hi. So the patients who are started on GLP-1 receptor agonists, and if they continue to have persistent diarrhea, I would be very careful in this particular patient population because they're much older, they're frail, and they're sicker. So you're right about that. And that's why I added that slide that this particular patient needs a very close monitoring when they are initiated on GLP-1 receptor agonist.
Thank you.
Did you find that any particular GLP-1 agent was more superior compared to the other, like let's say Ozempic, Mounjaro, or Wegovy? Like, did you find
That's a great question. So we did not compare the different GLP analogs. As of right now, liraglutide, semaglutide, and exenatide are the ones that have shown effect in the animal studies on and most of the clinical trials with cardiovascular benefits. So we just clubbed all of them together. We didn't do the subgroup analysis to figure out which one is better than the other one. Yes.
Did you report on the percent of SGLT2 inhibitor utilization between the two groups, just knowing the impact they can have on outcomes?
Yes. So in my slide, so in our study, we ended up including over 580 patients, and both the subgroup GLP-1 receptor exposed and non-exposed were matched even on SGLT2 inhibitors. In the real world, not every patient makes it on complete 4 GDMT drugs, but some of these patients, I don't remember the exact number, but I can. So yes.
Oh yeah, and they were similar between groups.
They're all matched, and only a percentage of population, about 35 to 36% of these patients were on SGLT2 inhibitor as well as GLP-1. Yeah,
thank you.
Hi, great presentation. I just had one question. Why did you start the database in 2005 when these drugs haven't been around that long?
Sorry, what?
You said the database is 2005 to 2024, right?
Yes.
So I'm just curious why you brought it back to 2005 when only the patients in one group would, some of the patients who have been on the drugs have to be more recent. They can't go back to 2005 because the drug didn't exist then. So is there any chance of bias by including patients who are from so many years ago?
So we did go back quite a bit, about 20 years, to try to capture as many patients with ATTR as possible. But to eliminate the risk of bias, we matched them. So some of these drugs are fairly recent, in last 10 years or so. So once we matched these drugs, we only ended up including the patients who were exposed to GLP-1 and the patients from the newer years that matched the cohort. We wanted to identify how many patients are there in the database which are diagnosed with ATTR cardiomyopathy, just to capture and figure out how many patients are there. Because ATTR cardiomyopathy diagnosis is not as common.
Great.
Thank you so
very
much. Thank you.